this is the first episode of Clinical Scoop with Dr. Al. We've got world-famous oncologist Dr. Al Jazairli, otherwise known as Dr. Al. I work with him for in his Los Angeles oncology practice. He does a lot of research now, and he's starting to branch into other areas of research. But in this first episode, we're actually going to discuss a couple of new trials and articles that we think are interesting. So we're going to actually get an oncologist's opinion on these trials and hopefully educate a lot of people in the process. We're trying to educate other physicians, other clinicians, other researchers, other people that want to be in research, the general public, because I know a lot of general public is actually interested in cancer because unfortunately cancer is so common amongst the general public. So this is going to be the formats for these interviews. It's not always going to be about oncology, but a lot of it in the beginning will be because Dr. Al is also going to be interviewing some of his colleagues in the future and other physicians from the community. And we're going to bring on all kinds of specialists. But today we're focusing on oncology and what's new. And Dr. Al, how's it going and what's new with you?
Very good. Thank you, Dan, for inviting me for this clinical scoop. And I'm very excited as part of your team in research and your CRO. Mainly, in my presentation today, I'm going to try to do some trial that's have a lot of a clinical impact on the physician and also on the patient. But as a part of your clinical scoop, Dan, I will suggest to have a feedback from the viewer and see what subject they want to talk about. Number one. Number
Absolutely.
two, we can convert from the clinical trial and also discuss about clinical practices, and we can go and take guideline from your book about that, which will be it will be one of the things and how to do what the responsibilities of the PI, what the responsibilities of the coordinators, how to run it, what the requirement for, a lot of field we can go in the research and we can cover it other than the clinical trial. More than happy to cover a lot of subject in the clinical trials and what's updated in that. I choose a couple of articles mainly about things that's done in the clinical practice on a daily basis.
Well, before we get to those articles, because I think that you made a good point. So before we get to these articles, I'm going to introduce maybe a little bit of what we're trying to do with the clinical scoop. So like you said, we're going to talk about clinical trial results. Sometimes we're going to talk about new clinical trials that just hit the market because we're really trying to target physicians and other clinicians and industry professionals who are curious about this stuff and want to hear the clinical results from the perspective and interpretation of a doctor, or it could be an oncologist, or it could be another specialist, depending on the study we're analyzing. So the clinicalscoop.com is where you want to go for these things. In the future, I will share the live stream link with everybody who wants to watch live as we're doing it, but the recordings, we'll keep the recordings. Once I accumulate 3 or 4 episodes, Dr. Al, I'm going to start the podcast, the Clinical Scoop podcast, where all the recordings are going to go. You can replay them when you're driving in the car. You can learn about study results. We're going to have all that stuff there. We're going to have our own YouTube channel. But right now, everyone joining us live, and we're sharing them on my YouTube channel for the time being. So thank you very much again, Dr. Al, for this idea. It's a fantastic idea you had to do this, and I love doing these kind of things because I had a similar idea a couple of years back. And it's funny how we both kind of came to the same idea, separately. But then when you told me about it, I said, hey, I've been thinking about this for 5 years. So I'm glad we finally got able to do it. And I'm looking forward to learning from you as well and watching you interview people and having others interview you. I think everyone, the whole community will benefit from this. So thank you again.
I think there's something in the internet. I don't know from my side, your side, or
Oh, okay.
Amir.
Yeah, now it's good. I think it's good now. So yeah, you want to go through the articles now? We can go through those articles.
Yeah, mainly everyday practice. Like I've been asked by the company, by the patient and their family about about the use of the supplement. Okay, and is it good for me to use supplement or not? And does it affect my chemotherapy if I use supplement, or does not affect my? And this is an original article from the American Society of Clinical Oncology, which is the main society that make the tool. And this is the SWOG studies, SWOG S0221. This is Southwest Oncology group, which is one of the biggest one that runs and they talking about the purpose of the study was to see the use of dietary supplement during cancer treatment before and after, and see if it's effect on the survival of the patient or on the disease-free progression. And mainly they had almost like 1,134 patient were going for treatment for chemotherapy with cyclophosphamide, adriamycin, and Taxol for the breast cancer. And they divided the supplement to antioxidant and non-antioxidant and iron supplement. And
Wow.
the antioxidant they included was vitamin A, vitamin C, vitamin E, carotenoids, and CoQ10, coenzyme 10,
Okay.
Q.
Mm-hmm.
And for
Yep.
for non-antioxidant, they use vitamin B12 as a supplement during the treatment with chemotherapy, and also iron supplement during the chemotherapy usage for the patient who have a breast cancer. And what they found is, interestingly, that all these three supplement can affect on the patient survival and disease free progression negatively. What do I mean? I mean that using the supplement before the chemotherapy and during the chemotherapy can affect on the outcome of the treatment for the patient. So the bottom line for the patient who's undergoing chemotherapy, not use any supplement at all unless they check with their physician, because
Wow.
the three category of the supplement, these are can reduce the life expectancy for the patient that's undergoing and make the cancer come faster.
Wow. So that's an important study. I was curious in another study that we don't have that study today to show, or to talk about, but I was under the impression that people who go on fasting, 72-hour fast or 48-hour fast prior to chemo tend to have less adverse events after the chemo than patients who eat normally. What do you think about this? Have you researched into this at all?
Fasting in general can help the patient, mainly in breast cancer, because we know fasting can reduce weight loss. Exercise and weight loss is the number one non therapeutic method that can help reduce the recurrence of disease and improve survival for the patient. And this is well-known study done in multi-centers, big study for the patient. They found these two factors. So directly fasting may not affect, but I think the weight loss that happened with the fasting can improve the survival of the patient and reduce the risk of recurrence of disease. Because
Okay, perfect.
we know there is a big correlation between body mass index and the recurrence of the breast cancer
Breast
and colon
cancer.
cancer, different type of cancer. And the more you get to your ideal body weight, the better prognosis and overall survival can happen to you.
And now this other article here, so that's a good one about the supplements. This other article here I see, can breast cancer surgery be eliminated from good responders to
Neoadjuvant
neoadjuvant, so
chemotherapy. Yeah,
exceptional responders is the study. So what do you think about
it
this? Like,
is.
what is this?
It is a very interesting study because a lot of direction is now to help minimize the side effect of treatment in general for the patient and improve their quality and reduce their comorbid condition that can happen to them. And one of the new adjuvant is giving chemotherapy ahead of the treatment, as we have on Dr. Hoffman's study, the Pfizer study for the breast cancer, where
Yeah.
we're giving the chemotherapy before surgery. We're trying to shrink the tumor and see what the effect on the patient. So this is the goal of the neoadjuvant chemotherapy is to shrink the disease and minimize the surgery for the patient. These are the patient that eligible for this an early stage cancer, stage 1 or 2, without lymph node involvement, where they can do the chemotherapy, shrink the tumor, and then try to aspirate the tumor without doing any surgery and work. And apparently in this study, they found that uh, there is almost comparable to the patient who have the same stage, the same disease. The outcome and life expectancy for both of them are the same. But this was a small study, and they want to take it bigger and do it through the SWAG, most probably in the near future. But as pilot study, it was very good for these patients and give them more hope about when they have a breast cancer, that they don't have to go through taking the breast out or doing mastectomy or having the side effect of that and having the distortion of body image and
Wow. This is important. Yeah,
etc.
I'm reading here.
It is very
In
important.
2014, this was in 2014, the colleagues estimated that after neoadjuvant therapy, about half of patients with triple negative or HER2 positive tumors may not need surgery based on a 50% pathological complete response rate in those subtypes. I don't know if the term exceptional responders really applies anymore because this is becoming more and more something that we expect, one of the doctors said. So at the 2020 Miami Breast Cancer Conference, Dr. Whitworth discussed the latest thinking on this topic, standing in for another leader in this field. Yeah, they're thinking that this is becoming the new normal. Is this true? Are you seeing this too?
But we in the community, I don't think we adopted this approach, but mainly in the university centers, yes, you see some physicians that do it through clinical trial
Wow.
mainly because it's not the new standard yet, and it have to have
Right.
you know have to have a big studies to apply the standard for the study and have it approved as the standard of care for more population. We have a lot of other options that can be done for the patient also in that regard, like even if they have lumpectomy or tumor resection, that they can have radiation inside the operation room for 7 days instead of going 6 to 8 weeks with the radiation treatment for these patients.
Yeah, and we should actually get Dr. Hoffman on because you mentioned the study that you and I are both working on right now. Is that because that's neoadjuvant and it's chemotherapy? Is that study anything to do with immunotherapy?
No, it doesn't have to do with
No.
immunotherapy.
Okay.
Immunotherapy
Okay.
is it's a completely different field of in oncology, but
Yes. Yes.
I think you know it is also possible to get Dr. Hoffman on board and try to get his opinion about
Yeah.
the new adjuvant and his study and what the future. But from what I see in the patient that I enrolled so far, it is a very promising study.
Yeah.
We
Lots of
had
good
like
stuff in the
four,
oncology
yeah,
space.
4 out of 6 or 7 patients, their tumor completely disappeared. But unfortunately, with this time and this era, I have to send him for surgery because this is the standard of care.
Yeah.
I cannot
That's the
just do
standard.
do
Yeah.
for him. Yeah, I have to follow the standard of care at this point, unless there is an open study to take to do only suctioning of the remnant tumor from their breast at this time.
Right. You want to talk next about the Paola 1 trial?
Paola 1 trial, very interesting trial, which is in the past for these patients who have ovarian cancer after they have the surgery and have the chemotherapy, try to improve their survival. We used to give them a whole year of Taxol, which is another chemotherapy which have a lot of side effects such as neuropathy, hair loss, and a lot of side effects that can happen for a whole year for the patient and was devastating. So recently they're trying to divert from this and start with giving the olaprinib, which is one of the PARP inhibitor for ovarian cancer, in addition to Avastin or bevacizumab, which is an anti-neogenesis agent that's given. Both of them are very effective in ovarian cancer, and it's used in metastatic ovarian cancer. But now this approach is trying to bring it as part of the standard of care as as maintenance treatment for the patient who have initially diagnosed with ovarian cancer and went debulking surgery, and then followed by chemotherapy and followed by the PARP inhibitor, in addition to the bevacizumab treatment to reduce the risk of recurrence. And they found that it is feasible. And I think this is going to be one of the practice-changing trial that can help and improve and reduce the side effect of that can happen to the patient in these type of tumors.
Wow. Wow,
Yep.
yeah, I'm reading it here. So in the future, we're gonna have infographics popping up. This is our first episode, but for those that are watching live, if you're listening on the podcast, doesn't matter. You'll get the same thing. But if you're watching the recording on YouTube or you're watching it live, we'll have infographics of the things we're talking about. So yeah, this is an interesting study. Anyone that wants to know more about the data for this, just get a hold of me or Dr. Al, and we can send you some info. We want this to be like a dialogue for educating other people in research and other practitioners out in the community. There was another article you wanted to talk about too, right?
Oh, you asked me for
The
how many
flyer.
articles there?
I think I
There
see
is like
another one here. The flyer
there is two
trial.
there is two articles that I want to talk about still.
Okay.
One is in colon cancer. Okay, patient who have stage 3 colon cancer, and now in colon cancer there's 4 stages. The stage 1, it is localized within the colon cancer. Stage 2, where it is go through the colon wall. Of stage 3, when it get involved in the lymph node. Stage 4, when it metastasize or spread in the body. But now there is a new definition for stage 3, which is like having, even without lymph node involvement, having the tumor deposit around the colon in the same area, which is, before in the old day we used to consider it as a stage 4, but now they found out that it, for these patients that they have the tumor deposit in the mesentery, their prognosis is worse than the one does not have it, but their prognosis is better than the one who have metastatic cancer. And the
Hmm.
treatment for them need to be same as a stage 3 colon cancer, and they have better survival than the metastatic cancer, and there's chance of being cured also. That is very
Do you know
interesting
where?
finding, because I'm sorry,
Yeah. Why is it interesting?
because the tumor deposit was not considering it in the past. We used to classify the cancer as stage 3 with lymph node involvement without considering the tumor deposit. But now we have a tumor deposit in the mesentery of the abdomen. It is part of the prognostic feature for colon cancer.
Do you
It
know
is.
where this study was conducted?
This is like, I think this is from the. It is from the ASCO, American Society for Clinical
Oh, okay.
Oncology. Yeah, and it is published in abstracts mainly in May 2020
Okay.
in the ASCO
Oh
journal.
wow, this is brand new. This is brand new.
Yeah, but
So this year
mainly,
ASCO was virtual, right? You did ASCO
yeah,
virtually, or
we have ASCO virtually, and a lot of abstract, a lot of literature came out in oncology, but also everything could be an observational or could be something uh, non yet clinical. Scientifically, it have very good merit, but clinically not yet there.
right, right. Interesting. Okay. It'll be interesting to see
And,
over the months, what comes out, what's new, what are your thoughts on it? And maybe we can even get some of these other doctors to come on and interview them about their study. Like, for
and
example, Dr. Hoffman.
yep, this is the last one is about treating lymphoma. The standard of care for
Okay.
treatment of non-Hodgkin lymphoma, aggressive type, is to do the R-CHOP. R stand for Rituxan, CHOP, C for Cytoxan, H for Adriamycin, O for vincristine, and P for prednisone. And this is used. This has been the standard for many years. But now they try. It is very heavy chemotherapy, can cause a lot of side effect and can cause a lot of morbidity things for the patient. So they're now trying, and usually we give 6 cycles, okay, and then we give maintenance Rituxan after that for 2 years, once every 3 months. But now is they're trying to do is trying to reduce the amount of the chemotherapy for this from 6 to 4 cycles and see if the for this type the same type of lymphoma and see if the patient can tolerate it and his survival will be as good as doing 6 cycle or not. And this is what they call it, the flyer trial,
That's
FLYER.
the trial, yeah. Yep. The
Uh-huh.
flyer trial.
And and they found out in this trial that giving less chemotherapy for these patients with B cell lymphoma can reduce without compromising outcome of these population and can help them and um, can maintain their survival same as giving more chemotherapy. Giving 4 versus 6
Yeah,
cycle.
chemotherapy can be reduced without compromising outcomes in this population, which are they're talking about young patients with aggressive B-cell non-Hodgkin lymphoma and favorable
Yep.
prognosis.
Yep.
Interesting. So this
So
R-CHOP is a new R-CHOP
no,
basically is the
it is the
new.
standard of care for treatment of non-Hodgkin lymphoma. The
Oh,
standard of
okay,
care for
okay, okay.
treatment of non-Hodgkin lymphoma. We've been using it for many years.
Okay, I got it.
But now for these
Okay,
patients to try to reduce the side effect because this can have side effect on the bone marrow, side effect on the heart and the kidney, uh, to see if reducing the comorbid condition can help these patients and maintain their survival same as more chemotherapy.
I got you. Okay. Yeah, wow. I'm seeing the safety profile here, progression free. Well, these are interesting articles we got this time. And these are new, these are fresh results.
Yeah, but my question for you is like there is a lot of specific things in the trial that we can make slide for it and go through it and do this, but I think this will be a little bit too complicated for the general population because they have to go through that unless they want to see this thing, unless they want to know it. Okay,
They
more
want to
than
know.
happy.
They want to know. It's gonna be mostly clinicians, but there are gonna be those patients they call the empowered patients that study this stuff. I mean, you know, some of these patients they know a
I know.
lot. They know
Yeah.
more than most doctors about this stuff. So we're gonna attract those kind of patients too. Um, but yeah, I think this is all interesting. And the good thing about this is clinicaltrials.gov. I mean, we're at the busiest stage of research we've ever been, and that's in the middle of a pandemic. I mean, we can talk about the coronavirus studies in future episodes because there's a lot of those now. A lot. and I know a lot of people are interested in that as well. So let us know in the comments, and you can all text me 949-415-6256 to let me know what you'd like to hear more of and what you thought of this and what you think of the format. And we're going to get other guests on. And if you are a guest that wants to come on, and I know a few people that already want to be interviewed, Dr. Al, so we're good to go on this stuff. You're going to be an excellent host for this show, and I will be your co-host, just providing some comedic relief.
Great, Dan. I'm glad that we launched this podcast and we start doing it. I think it's very exciting, but
We did the
it's all
first
like we
one.
experimenting. Yeah, we experimenting. We need to get it to the best shape that everybody can enjoy it, can learn from it, and will be for the physician, for the general population. And we don't have to stick to oncology. We can study a lot of things. We can bring a lot of subjects into it, from internal medicine to cardiology to, we can interview a lot of physicians that they can help in this study. If you have any question or anything, just let us know.
Excellent. Thank you, Dr. Al. Thank you, everybody, for watching live. Message me on Instagram if you want the next live link. It's Dan Sarah, like my name underneath here is my Instagram. And like I said, you can text me as well. And thank you, everybody. And we'll see you next time. We'll do many more of these. Take care.